Hello, welcome again to Bipolarcast. This is a podcast where we talk about metabolic ketogenic therapies for bipolar disorder. We interview people who have experienced using these therapies themselves and psychiatrists and people who deliver these therapies to people with bipolar disorder. Today, we're very excited to have Georgia Eid on the show. Georgia Eid is a Harvard-trained board-certified psychiatrist specializing in nutritional and metabolic psychiatry. Her passion is empowering people with psychiatric conditions to reduce or eliminate the need for medications by changing how they eat. And she asked what changes are worth making and why, and this is what her work has been about. She was a Harvard-trained board-certified psychiatrist specializing in college mental health and nutritional psychiatry. She has 18 years of clinical experience in hospitals, community health centers, specialty clinics, and private practices, utilizing medications and psychotherapy to help adults of all ages. She served as a staff psychiatrist and nutrition consultant for 7 years at Harvard University Health Services and for 5 years at Smith College in Western Massachusetts. In 2019, she established a new online video consultation service for individuals, families, and fellow clinicians to support people using special diets to treat psychiatric and other medical conditions. In addition to writing all of the content for her website, diagnosisdiet.com, she's a regular contributor to Psychology Today and dietdoctor.com, and she speaks internationally about nutrition science and mental health. Thank you very much, Georgia, for coming on today.
Thanks, both of you, very much for having me. It's a pleasure to be here.
We're super excited to have you on the show because you've been ahead of the curve on pretty much everything to do with diet and mental health. Like when I watch back your interviews, like the one you did on Diet Doctor with Brett, you were talking about plant anti-nutrients and kind of carnivore approaches and the serotonin hypothesis. And this was probably, 7 or 8 years ago. When you were studying at Harvard, how did you make the transition from, because a lot of people must have been very wary of dietary approaches, and what made you able to recognize the significance of this and to make it your career when many other people would have been skeptical about this?
Yeah, so as I'm sure you know, in medical school, we probably receive 2 or 3 hours worth of nutrition education in 4 years. And in psychiatry residency, which is also a 4-year long training program, we didn't discuss nutrition once, not even when we were talking about eating disorders, which is, which is a food related condition. So I, like so many other women, viewed food, diet as a way to control my weight. I never thought about it as anything that could have, as a powerful metabolic intervention that could prevent, I believe, in many cases, I think that's likely, and treat and stabilize a wide variety of psychiatric conditions. So, one of the things I like to say is, the most powerful way to change brain chemistry is through food, because that's where the brain chemicals come from in the first place. So, what I was trained to do as a psychiatrist was to administer medications and to conduct psychotherapy. And I enjoyed both of those things very much and practiced like most other psychiatrists in the world practice. I practiced in the dark, literally without any guiding principles, even around medication management. There are really no, how do I put this? Let me give you an example. A patient comes into the office with depression. There are many different types of depression. Bipolar depression, as you know, major depression was considered unipolar depression without manic highs, and many different types of anxiety disorders that depression often comes with anxiety. So when a patient comes into your office, you are trained to take a history of their symptoms, and you are trained to look in the DSM and see if their symptoms fit into one of these neat little boxes. And they almost never do. The DSM is not a very useful book. It's really not very helpful to clinicians. And these diagnoses are not, for the most part, biologically based. They're not grounded in biology. And the brain really isn't divided into different sections, depression section and a bipolar section and a psychosis section and a memory section. It's of course intricately linked. All the parts of the brain are intricately linked. So we weren't really taught to think about anything beyond childhood experiences, symptom patterns, and neurotransmitter imbalances. We never were asked to think about well, what's causing these imbalances in the first place? And we never talked about brain metabolism. And so that's the way I practiced. Literally, I mean, it felt as though I was practicing trial and error tactics in my work. I love my work. I love working with patients. I love taking their histories. I love getting to know them. I love doing psychotherapy. But I really didn't have a roadmap, despite all the 8 years of specialty training at some of the best schools that a person can attend. I still felt like I was kind of throwing things against the wall to see what was going to stick. Let me try this medication, see if this works. Okay, well, if that doesn't work, let me try this one. And it's really frustrating for both patients and physicians to go through this arduous process, which is doesn't often bring the results that we're hoping for. And medications do help some people, and they're really important tools in the toolbox, but they don't address the root causes. Most of them don't address the root causes of mental illness. So how did I become interested? I wasn't interested at first. I never thought about it, but it really was like so many other clinicians who now practice in these new ways, using nutritional and metabolic interventions in their work. It was through my own my own health experiences that I stumbled onto this idea that maybe what we eat affects the brain. And it really was, and I won't go into the long story because I've talked about it many times before elsewhere, but essentially I was noticing a lot of health issues, fibromyalgia, chronic fatigue, migraines, IBS, a variety of different symptoms that were interfering with my ability to function in my early 40s. And simply through trial and error changes in my diet, I was able to reverse all of those things. And the diet that I arrived at, and this was in 2009, so a very long time ago, was what a lot of people would consider unorthodox, kind of upside down compared to how we're taught to eat. And nobody was more surprised than I was to discover that that eating more meat, more fat, less fiber, fewer plant proteins. Nobody was more surprised than I was to discover that this was such a powerful intervention. And not only, and I've heard many of your stories on Bipolarcast and many of my own patients' stories, it isn't just that you feel that the symptoms are improving of whatever it is you're trying to address. What I hear over and over again, and what was true for me, is you feel better than you've ever felt, as though something fundamental has shifted, and in your mind and your body. So I wasn't trying to treat a mental health condition. I had, some garden variety depression and anxiety, seasonal depression, stress, etc. I'd had, my share of those things, but nothing ever, clinically diagnosable, nothing ever serious. But I noticed when I changed my diet in this way that my mood was better, my energy was better, my concentration was better, my stamina was better. I mean, everything was better. And I remember writing in my, because I was keeping a journal at the time, a kind of food and symptom diary over 6 months to see if I could help myself feel better. I remember writing down in my journal, this diet is peaceful. There's something about it, and peace of mind. That's what we're all looking for, right? And so it just got me thinking, if this diet helps me with my mental health, and I wasn't even trying to improve my mental health, could this help all of the patients who come to me, and all of my colleagues as well? All of us have patients accumulating in our practices who aren't getting better. There are a few people who improve a lot. There are some people who improve enough that they may not need to come very often. But the majority of patients, I think if any clinician you talk to will tell you this, if they're practicing conventionally, the majority of people that come to them for years and years and years for medication refills, for support around whatever it is that they're dealing with, but we're not really getting to the root of the problem. And it's So that's how I came to practice this way, and over time incorporated to a greater and greater degree these principles into my work.
That's an amazing story. And it's funny because we talk to a lot of people who have arrived at these conclusions about keto and about metabolic interventions independent of each other just through the same method you did, trial and error, trying out different diets. What was the journey like as you started to incorporate some of the nutritional changes into your practice, into your patients' lifestyles, I should say?
Yeah, so at the time that I was doing this for myself, and I really studied. I became a student of nutrition science, which I had never read a nutrition science article in my life until 2007 or so. And because when I turned my diet upside down like this, I was genuinely concerned that this diet, which had, reversed all of these conditions, was going to kill me because it was high in animal foods, high in saturated fat, high in animal protein, lower in fiber, didn't contain any grains or soy or anything like that. I was really concerned that this was unhealthy. So I dug into the nutrition science, and I read for a long time and studied for a long time before I decided to incorporate these principles into my, because I wanted to make sure they were safe. And I was working at Harvard, the Harvard Student Health Service at the time, or back then that service was not just for students, but also for faculty and staff. And the director at the time of the University Health Service was supportive of my incorporating nutrition principles into my work. And so allowed me to, include in my bio on the website that this was one of the services that I offered. I mean, obviously I was hired, just like all psychiatrists nowadays are hired, I was hired to prescribe medication, but they were very supportive of my including this as an option. So I did have some people coming to me specifically to talk about that. And in the beginning, all I did was just encourage paleo principles, just whole food principles, lower carbohydrate, healthier forms of carbohydrate, whole foods diets. And then there was a change in leadership, and the new director, who's no longer there, the new director called me into her office and said, nutrition strategies are beyond the scope of psychiatric practice, and we need you to stop immediately. And I was heartbroken. I was literally heartbroken because this was a really a passion project for me. And half of the reason why I went to work every day was because I was so excited about what was possible, that I finally had something new to offer people that wasn't just random trial and error medication options. So I left Harvard because student mental health was my specialty. I left Harvard and went to Smith College, where they would support my incorporating nutrition principles into practice. I encountered resistance from the wellness department and the dietitian on campus. Again, got called into the office and was told, you can't, I mean, I wasn't attempting ketogenic diets in Smith College students. That's not a feasible strategy on a college campus to try to single-handedly put students on a ketogenic diet. I was simply encouraging people, whole foods, lower carbohydrate diets. Let's try, for example, reducing how much, let's take a look at how much sugar there is in your diet. And we'd have these conversations about how sugar can be damaging to the brain. Let's just talk about cutting down on sugar. And that got me called in wellness director's office, because their philosophy was everything in moderation. If you tell students to fear a particular macronutrient group, you are going to encourage eating disordered behavior. So there were a lot of limitations on what I could do there after that meeting occurred. And so, and it's, college, both of you know this, that eating culture, food culture on college campuses is atrocious. And the food choices on college campuses, it's very interesting. At Smith, for example, and Harvard was the same. There were all these different specialized dining halls. You could go to a vegan dining hall, you could go to a vegetarian dining hall, you could go to There was even a dining hall dedicated just to pasta for people who were athletes and all kinds of special diets, but no Whole Foods dining hall, no dining hall where you could go where you weren't going to face a buffet of sugary desserts and treats and sodas at every meal. So if you were trying to eat healthier, it was going to be really challenging. And of course, the college campus culture, staying up late and pizza and ice cream and so on and all that kind of stuff. And wellness events, well-intentioned wellness event directors would lure students to wellness events with refined carbohydrates. So let's come and talk about sleep and concentration and meditation and self-care. Let's talk about those things in front of a row of cupcakes. And that's how you get students to come. So anyway, the reason why I'm going into this isn't just that I think this culture needs to change, or at least that there need to be options for students who are trying to actually feed their brains the right way, because you go to college to learn. And how can you learn if you're not feeding your brain properly? So, but the other reason I bring it up is because after 5 years of trying to do nutrition, and I always had a private practice on the side where I was doing strictly nutrition work, so that was lovely. But in these settings where I was practicing my specialty, which was college mental health, I was finding it almost impossible to do the kind of work that I wanted to do. So in 2018, I left Smith and decided to step out on my own and do exclusively nutrition-oriented work. And the cornerstone of my work is the ketogenic diet, which is an incredibly powerful intervention, as you both know. But I also use other nutrition strategies in my work as well. So,
I just want to acknowledge that a lot of people who work in this, like yourself, have to make tremendous sacrifices to be able to do this. You were at Harvard. You probably, I'm sure many people would have worked a whole career to get into a position like you're in, and you actually gave that up because and this is something that I think as patients we appreciate the most, is psychiatrists who really care enough about their patients to take the risk to do something that's really going to help them. And I can't imagine how stressful that must have been, having your boss and people telling you can't do this, and then you having to move out on your own to do that, and then to move again when someone else. So there can be never enough thanks from patients for making those kinds of decisions, because they're the decisions that no one makes, but they're also, I think, the decisions that can really change things. And so thank you for doing that and for stepping out at a time when it must have been, I think when I first discovered the diet, there was literally your website and Chris Palmer was talking about it, and that was it. There was no one, and I was thinking, I honestly questioned myself at the start whether this was a good idea, because I knew it was helping me, but it was only finding your website and Chris's website and then thinking, oh, this is actually a real therapy that people use and has worked for people, and I found out about epilepsy. But yeah, you were saying this right from the very beginning when nobody else wanted to. So thank you for doing that and for helping so many people to learn about this. Did you ever foresee this becoming the movement that it's starting to become with kind of metabolic psychiatry? I mean, you've been doing this long before these terms were even in use. What do you is it nice for you to see other people starting to publish about this and believe in this and to practice it?
It's wonderful. It's a dream come true to see other very intelligent, very skilled psychiatrists taking these matters seriously, studying them, researching them, implementing them in clinical care, spreading the word. I've never wanted to be the only one doing this. We need every psychiatrist, every nurse practitioner, every mental health clinician, prescribers in particular, but all mental health practitioners to learn about brain metabolism and learn how to incorporate these strategies into their work, because there's just a handful of us doing this right now, and it's not enough. I mean, the demand for these treatments is huge. I mean, and you know that we're all connected through a metabolic psychiatry email group, which is lovely to have that community of support and reflection and learning from each other and supporting each other. And we've had conversations on that group saying, we're getting emails every day. I get 2 to 3 emails a day from patients seeking care who want to start a ketogenic diet to help reduce their need for medications. And, there just aren't enough hours in the day to see everybody who wants to be seen. And that is heartbreaking. So this is, I'm really excited that other people do this. I want more people to do this. I want everybody to be able to have this option. I want them all to be given this option when they walk in the door for help.
Yeah, and I mean, thank you for people like myself and Matt who found this early on. It really helped to know that there was someone who was a legitimate scientist and a psychiatrist who was endorsing this, because it was very hard to justify it to yourself without that kind of. So it's obviously helped countless people through your training and through people just knowing that you're endorsing this. So thank you for doing that at a time when a lot of people were, obviously scared to endorse this or to talk about it. Also, like when you look back through podcasts that you've done, you've said a lot of things probably, I'd say 10 years ahead of when they've become popular news, like about serotonin hypothesis, about plant anti-nutrients, things that are very unpopular at the time. I mean, what would at the time there was very few people saying that. Did you feel like being contrarian, or were you just so convinced by that? Because yeah, I imagine you must have received a lot of pushback. Now these ideas are more commonplace: carnivore, plant anti-nutrients. But at the time, did you experience a lot of pushback from when you were working at university or working in the places you were?
Well, I would say that most of the pushback came, again from, people in power at the institutions that I worked at who might not have, who thought, and I understand this, I do understand this, who thought that what I was doing, that it wasn't quite ready yet to be done, that it was too early, that there weren't any randomized controlled trials, and et cetera, et cetera, et cetera. But as we all know, we have 100 years of science, 100 years of really in-depth, robust science telling us that this diet, this ketogenic diet, is good for the brain, stabilizes brain chemistry, heals the brain in many cases. Through epilepsy research, we understand this. That was, really one of the epilepsy is a brain disorder. The brain isn't divided into neurology cells and psychiatry cells. It's one organ, and so it's just that psychiatrists treat conditions which manifest themselves as emotional and as problems with emotions and thinking, and neurologists treat the conditions which manifest themselves as, sort of seizures, for example, physical symptoms. And but this is an imaginary line between these two fields. And so what's good for the brain is good for the brain. So I felt, and rightly or wrongly, I felt, okay, what about all the people who can't wait for randomized controlled trials? What about all the people who are suffering now, who are interested and willing to give it a try? And I wasn't in a position to to conduct a randomized controlled trial, and so I thought, well, why not implement this or offer it to people who are interested? And so in terms of some of the presentations that I gave about, questioning the benefits of plant-based diets, or questioning the wisdom of including certain types of plant foods in the diet, questioning whether or not meat is actually bad for you, digging into all of that. I love thinking about those things. I'm very, very interested in food chemistry and how food behaves in the body and affects the brain. When I give those presentations, there can be sometimes some pushback, but most of the pushback is on social media, where there's a very polarized community. People have very, very strong feelings about food. And I understand that. I mean, it's a hot topic. It's like talking about religion or politics sometimes. I mean, we're talking about food. I mean, it's just kind of, as a psychiatrist, it's interesting to observe, how strongly people respond to these things. But, I didn't see the need to wait. And but I also do understand, some kind of an early adopter of the science of hope. But there are other people, I understand, on a bell curve. There'll be lots of clinicians who are on the other side of that curve and really are going to want to wait and see results of trials like yours, Ian, and trials like Dr. Shabani Sethi-Dalai, and the increasing number of trials that are going on around the world, thanks in no small part to the Bozuki Brain Research Fund, which is just fueling a movement, and which is just incredible. So there are lots of clinicians out there who will not offer these therapies to patients until we have randomized controlled trials. And I understand that, but I also think that if we wait for randomized controlled trials of the ketogenic diet in every specific psychiatric condition, while people are suffering and feeling suicidal and self-injuring and despairing and dropping out of college and losing their relationships, losing their jobs, I don't know. I guess where I want to be is helping people now and helping clinicians now who are willing to be early adopters of this strategy.
It's funny because you wonder, like, what could be worse than a diet of 70% refined carbohydrates and sugar? Like, is it going to be worse? So what are we doing?
Exactly. So one of the things I say to, I teach a ketogenic diets for mental health clinician training program, and in that training program I say that the whole first module is dedicated to science and safety, and this question of I built that whole module to answer a question that I was asked when I was serving on an international expert panel on nutrition and mental health a couple of years ago. One of the other panelists said, why would you want to use an extreme diet like the ketogenic diet to treat mental health conditions when there's no good evidence to support its use? And one of my answers, one of many answers, is, is the ketogenic diet safe? Is it extreme? Is it safe? Well, nobody ever asked that about the modern Western diet, which should come with a skull and crossbones on it. It's that dangerous for health. And it's just compared to what? Ketogenic safe compared to medications, which can cause diabetes and obesity and all kinds of other health problems, sexual side effects, lethargy. People sleep all day. They feel really tired. They gain a lot of weight compared to that. So I don't. When you know what you're doing, a ketogenic diet is quite safe for most adults, provided that the medications and health conditions are properly monitored, and that there's good support and education to just, especially through the keto adaptation period. So I view it as one of the safest interventions I have to offer.
So you have this CME clinician training program in ketogenic diets. Could you tell us, and so you're now training other people to use this diet as well, and it's amazing how many people in this scene have come to this program. It's really educated a whole generation of people about using this. Could you tell us a bit about the program and what's involved?
Yes, so it's right now the way I teach it is in small groups, live virtual sessions, maximum of 6 clinicians per group. So it's 5 90-minute modules. So we meet once a week for 90 minutes for 5 weeks in a row. And I've been teaching it since early 2020. I've run it about 25, 26 times now. And we've gotten clinicians from all over the world, something like more than 20 countries, 5 continents, different types of practitioners, not just prescribing clinicians. We have many psychiatrists and nurse practitioners, but also psychotherapists, health coaches, other people who want to support, and dietitians and nutritionists, people who want to support patients as they implement this diet to see what might be possible for them. So that has been, that's my way of trying to increase access for patients who are seeking these services. And the next classes start, by the way, in case anybody who's watching might be interested, the next classes begin on October 20th. So if you go to my website, which is diagnosisdiet.com, there's a training page, training tab, and it explains how to sign up there.
We'll put the links to that in the description, diagnosisdiet.com/training. And yeah, this is absolutely the best possible way to learn about this. So, I mean, I think it's just incredible how many people we've spoken to at Keto Live. So many people are coming up and saying, oh, I've gone on Georgie's course, and it benefits from all your experience of doing this over such a long time. So if anyone's listening that's a psychiatrist, and there's a lot of psychiatrists who do listen and email, please do check this out, because it benefits from all that experience and learning through doing this over, I think it's 18 years that you've been using it. Is that correct?
Well, let's see. I started using ketogenic diets in my work in private practice in 2009, so 13 years. But again, other dietary interventions as well. But yes, I have a lot of experience using ketogenic diets. And one of the nice things about the training groups is that it is live, it's interactive. We have discussions, Q&As, and that's one of the, and clinicians of different disciplines. What I think people have told me they value the most about the class, in addition to the content, which is helpful, is the interaction, the interactive element where we can learn from each other, they get all their questions answered in a kind of a safe, supportive environment.
We just had Patrick Kennedy on the podcast, and he joined your course, and he was absolutely raving about it. He really loved it, and I think he's a primary care doctor, but very interested in how keto and low carb approaches have been helping his patients even at primary care level. So you've been having this CME clinician training, which is helping a whole lot of people to learn about how to deliver this therapy. But you've also been you made a huge impact recently with research with Dr. Dannon, where you had this study in Frontiers in Psychiatry, and you were publishing about these 13 bipolar patients. There was a number of different conditions looked at, but there was these bipolar patients who'd seen a significant reduction in symptoms. And if you look at the improvement they experienced, you very rarely see that level of improvement in any bipolar trials. So I was quite shocked when I saw what was being reported. How did this come about, this study?
Well, Dr. Albert Dannon, who is a psychiatrist with roughly 30 years of clinical experience in Toulouse, France, who has been treating people with serious mental illness for decades, and has worked with many of his patients for decades. Who's a wonderful clinician and a wonderful human being. And so he reached out to me a couple of years ago saying that, he had witnessed a family member with an adolescent family member with autism and epilepsy. He'd witnessed that family member improve within a matter of weeks on a ketogenic diet, and both the autism symptoms and the epilepsy symptoms. And so this got him thinking, I wonder if this intervention, which seems to be good for the brain, could be good for my patients too. And he read and studied about the diet and began using it in his outpatient work, used it on himself and in certain outpatients, and then went to his local hospital where he had admitting privileges and where he would admit his patients when they needed inpatient care, which the Clinique de Castelville. He went there and he said he proposed setting up sort of a makeshift metabolic psychiatry ward within a general psychiatry inpatient unit. And because he had long and good relationships with the directors of this hospital, he was able to convince them to let him do this with his patients. There was a lot of resistance from the dietitian, of course, and he of course needed her on board. And so that took some time, but that eventually did happen. And so he asked 31 of his patients, actually 32, there was a patient with OCD that we excluded, 31 of his patients, if they would be willing to voluntarily come into the hospital to try a ketogenic diet under medical supervision. And these were patients who had, many of whom he'd been working with for 5, 10, 15, 20, 25 years, serious mental illness, 12 with bipolar disorder, 10 with schizoaffective disorder, 6 with major depression. These are very seriously ill patients, many of them on psychiatric disability, about half of them of North African descent, half of them of French descent. And he put them all on a ketogenic diet. And he met with them every day, except Sundays, I believe. And administered the snacks, monitored their dietary compliance, support, education, everything you need to do this well. And the results were really remarkable. So when he contacted me to tell me that he'd done this, he was really just reaching out because he was alone in doing this and he wanted to talk to somebody about it. I said, Albert, this is incredible. Nobody has ever done this. No one's ever done this before. And he said, they haven't? I mean, I think that especially where he's in French and French is his first language, he wasn't aware that this had never been done before. And I said, I wonder if we could get this published. You don't have a control group, but I think this is really worth people knowing about. And so we worked with Dr. Eric Westman and Dr. Laura Saslow, who have published multiple articles in this field. We worked with them to write this, to analyze the data and write this paper and publish it in June. And we have been just thrilled to see how much interest there's been in this paper. And it's been viewed almost 50,000 times now. And the altmetric score, for people who know what that is, we're in the top one percentile of attention for this work. And this is I think really lovely, because until now we've had some beautifully written case reports. We've had some excellent examples of individuals trying this diet and seeing remarkable results. But until Dr. Donald's work, we didn't know how many of those people were outliers and how many of those people were special cases. But if you take 31 people and all of them improved to some extent, and 43% of them achieved clinical remission, and the effect sizes on the mental health markers are enormous, and it's very hard to explain those outcomes. There is no control group. We can't say definitively that the ketogenic diet was the reason for these results. But how else would you explain it? I mean, we haven't seen, like you said, and we haven't seen results like this for serious mental illness, no matter what the intervention has been. And all of these patients had been hospitalized at least once, or often multiple times, at this very same hospital or the sister facility, which uses the same treatment protocols. So they'd never improved this much, and a large number of them were able to come off of psychiatric reduce their psychiatric medications, and 24 out of 25 of the patients who were taking antipsychotic medications, which are famous for causing weight gain, 24 out of 25 of them lost weight, and half of them lost what is considered a clinically significant amount of weight, more than 5% of their body weight. And any clinician who has ever worked with somebody taking an antipsychotic medication, it is extremely difficult to lose weight. In fact, weight gain, no matter what strategy you're trying to live, weight gain is the norm. I've had patients gain 60, 70, 80, 90, 100 pounds on medicines like Zyprexa and risperidone and Seroquel. So that outcome alone, even if mental health doesn't improve, that alone, I believe is justification enough to consider this intervention as an adjunct to psychiatric medication to counteract some of the horrible metabolic side effects of these medications.
When I was eating a lot of carbs back in the day, and I went on Zyprexa, I just ballooned. It was wild. Why do you think it is that so many professionals are not willing to not necessarily accept, but even entertain the idea that your diet can have a tremendous impact on your mental health?
What a good question. A few thoughts on this, because I've had long discussions, even with close friends, who are colleagues of mine who don't support the work I'm doing or or are skeptical of the work I'm doing. It seems that most physicians, the culture of medicine is extraordinarily conservative and fear-based. I mean, you are taught that you are responsible for everything that happens to your patient. And so you are really, really bound by these guidelines. You don't want to practice outside the box, because if you do and something goes wrong, you could be sued. And this is a very real fear. This is logical. This is reality. Anybody who's ever been through a lawsuit can tell you that that is a nightmare. And so there is this first do no harm principle of, if I don't have enough information to support me, if I don't have a tribe, my medical association, the American Psychiatric Association, or whatever tribe you belong to, if I don't have that official support, I can't do this. And it takes time to learn how to do it. Most doctors are overwhelmed with too many patients. The visits are too short. And frankly, many doctors aren't interested in nutrition. The culture of medicine is, kind of sexy interventions like surgeries and fancy medications and, expensive procedures. That's kind of prescribing and conducting. So that's what makes you a doctor, right? That's what separates you from everybody else, is that you can do these things that nobody else is allowed to do. Well, nutrition seems like such a lowly intervention. Isn't that something we can just let other people do? But good nutrition is the foundation of good metabolism and good health, of course. And we're not taught in medical school. We're taught very little about healthy systems. We're taught about pathology. We're taught about, this is what goes wrong in the body, and this is the medication you can use to fix it. And I think most medical students would welcome the opportunity to learn more about nutrition and metabolism. And but I think once you've been indoctrinated into the system and you're overwhelmed and you're busy, you don't have time, and maybe you don't have the interest in these kinds of interventions.
I think just speaking as someone with bipolar and who speaks to many people with bipolar, like, you are a hero to us for doing this, because you were doing what really helped your patients versus what would be good for just think of what would be good for your career. And that is the thing we've always needed, is people to think that way, because it's always been, and I know, it's very hard for people if they're kind of going against the traditional way things are done to make progress, but you found a way through it by setting up your own private practice. And so there can never be enough thanks for people that like yourself that have done that have taken this route to. And I think it's just if anyone is a Nassim Taleb reader or something, it's like skin in the game, something that really works. When you're in with patients and seeing them day to day, you can't help but notice what is really helping them. And similarly with, Matt, and you were saying you'd gone through the American healthcare system. Was it like 40 treatments you tried, or?
I was hospitalized. I tried dozens of medications. I tried all kinds of weird stuff with various results, and nothing even close to the effect that keto had on me. Not even close.
Yeah, and so from a patient perspective and a psychiatrist perspective, there's a signal that's coming out of the noise that's but you have to be really with your patients and caring about them to notice that. Otherwise, you're just trying everything that's been tried before. So you're writing a book. So at Keto Live, we got to go to this conference in Bergen, which was fantastic. I was just absolutely wonderful, that place, to spend a week there. And then you stayed on for a few weeks to work on your book that you're writing. Could you tell us a bit about the book?
Sure. Well, first of all, it was so nice to meet you in person there after having read so much of your work, your scientific research, which is phenomenal and so illuminating to those of us clinicians who are trying to understand how these interventions work and what's going on inside the brain when we use these interventions. It's just fantastic. So, but meeting in person was great, and hearing your presentation about your new bipolar keto study, which I'm really eagerly awaiting the results of. So the book that I'm writing has been, it's an idea that I've had for a long time, probably about 10 years, wanted to write this book. And it'll be called Change Your Diet, Change Your Mind. And it is really the pillars of the philosophy in this book is teaching people, sharing with people how to nourish, protect, and energize the brain through nutrition. So the nourish piece is understanding which foods actually deliver nutrients to the brain effectively. Protect is understanding which foods damage the brain, can damage brain metabolism, damage the gut lining, damage the blood-brain barrier, et cetera. And then understanding how to safely energize the brain to preserve healthy brain metabolism throughout the lifespan. And that's all about making sure that your blood sugar and insulin levels are under good control. And so those three pieces, there'll be sections in the book debunking nutrition, the conventional nutrition science, nutrition dietary recommendations, sections in the book about different food groups, understand, why, for example, grains and legumes are not necessary and not recommended, things like that. And then explaining how refined carbohydrates work to damage healthy metabolism. And then the whole second section of the book is specifically about nutrition and mental health, brain metabolism, and then specific dietary strategies that people can use to discover to what extent the way that they've been eating has been contributing to their mental health problems. So these plans are designed to quickly help you figure out whether diet is the problem. And for most people, it is, not for everyone. I mean, obviously, even the best diet in the world is not going to help certain people, and that's okay. But in my practice, I have found the vast majority of people improve to some extent by making healthy dietary changes, and many improve substantially. And so it's a very, very high yield, sort of high benefit, low risk strategy. So that's what the book will be about.
Fantastic. And is it available? When will it be available to pre-order or to pick? Will it be on your website?
Oh, absolutely. So the book is the tentative publication will be September 2023, and so that's the date that we're shooting for. And I will, of course, be letting people know more. The pre-sale season probably won't be until at least next spring, but I'll definitely notify people and let people know. Yeah.
Fantastic. There was something I wanted to ask about on Twitter earlier. You gave this really, it was a description that struck me as really intuitively right. That you said that brain sort of energy in bipolar is it's like a sputtering kind of system. And there was something that really rung true about that. That's really what it felt like to me when I'd feel sort of like these kind of like moments of happiness or like the potential to feel happy, and then it would just descend into depression. And it was almost like I used to describe it like it's like when I don't know if this is maybe I'm just old school, but when you started a lawnmower, you used to have to pull this cord, and I think I'm sure there's buttons for this now. But when I was younger and doing the lawn, you used to like pull a string, and oh gosh, like I can't. But yeah, it was sometimes it just wouldn't quite catch, and it wouldn't quite. And that's what my brain felt like. I was pulling, the string to try and start the engine, trying to spin it up, but it would never just quite catch and generate enough energy. I was just interested where you that idea of like a sputtering kind of energy came from. It really rings true to me.
It came from reading your paper, Ian. And so when I read your paper, I I need to be able to visualize mechanisms. And so when I was reading your paper, I was trying to come up with a metaphor, trying to come up with, how can I explain this to the average person?
I'm genuinely not trying to ask about my paper. I just meant I thought maybe you'd heard this from patients or from, long speaking to lots of patients, because it's a very, I've never heard someone describe it that way, but I think that's exactly what it is. Most psychiatrists, when I speak to them, they, a lot of them have an extremely nuanced understanding of this, but generally it's considered mania and depression as this binary thing. And you're asked, are you in a manic phase or are you in a depressed phase? And I would try to sort of explain, this is way more complicated than this. My energy in a single day can go from being hypomanic to suicidally depressed in a single day. And even within a single hour, sometimes your moods can shift drastically. And so that it felt much more to me like a sort of faulty connection on a light switch than some kind of binary on-off manic. I just wondered if you'd seen that with patients over time, or it'd be really interesting to understand more about how dynamic this is, and it's not like a binary thing.
It's not binary. I mean, your experience is the norm. And so, from talking to thousands of patients over 20 plus years now, if you're paying attention, it's obvious that it's not up, down. Yeah. It's obvious, I mean, and I used to try to, we'd have these conversations with people, they would try to describe to me how they were feeling. Mm-hmm. And from listening to how people describe this condition, it is not an up-down condition. It's a condition, it's really three-dimensional. It's coming at you through all different axes. So you can have mixtures of high and low together. You can move sideways. There are lots of, really, it's not an up and down thing. And I think for so many of my patients, I can't tell you how many hours I've spent in my career helping people with bipolar disorder, especially bipolar type 2, to understand that when they read a description of bipolar disorder, it's not going to resonate with them, because the way it's often described is simply not correct. And that their experience, it is a form of bipolar disorder, to try to convince them that, this was back in the day when I was, using mostly medications, trying to convince somebody to consider a mood stabilizing medication rather than an antidepressant. This was a conversation I'd had thousands of times. And if you have that conversation in a kind of open and compassionate way, where you're listening and really having a conversation rather than just telling somebody what you think they should do, you come to this place of, okay, that makes sense. Maybe this isn't just depression. Maybe this isn't just anxiety. And this sputtering, this is a word that came to me as I was reading your paper, quite honestly. That's when people would come with, if anybody who knows any with bipolar type 2 in particular, it's this funny, emotional roller coaster where it's not just up and down, like I said, it can be sideways, come out at you, through the screen, kind of all the different axes. But you get these glimpses of good, solid, clear. You get good days. You get these days or these periods of time when people seem just great, and not too high, not too low, not too anxious, just great. And they try to hold on to that. And it doesn't matter what they do. I mean, their life could be going perfectly well in all respects. It just disappears for no reason at all. And so, and the other piece about bipolar disorders of all types is anxiety. And I think this came up on one of your recent podcasts too. So many people with bipolar disorder are misdiagnosed with an anxiety disorder. And because that sort of energy, that uncomfortably high energy state, which we'll call mania or hypomania, whatever you want to call it, that uncomfortably high energy state can manifest as anxiety or obsessions, compulsions, ruminating, sleeplessness, all kinds of other things, but not necessarily meet criteria for mania or hypomania. It's a particular type of anxiety. And it's just extreme obsessive worry, and just it feels, and I would say the brain is in overdrive. The brain is in overdrive. And so these conditions, I think we need new ways to think about them and new ways to talk about them and new ways to write about them so that people see themselves in these descriptions and can relate to them so that they're not getting antidepressants. SSRIs in particular, as both of you know, can be dangerous for people with bipolar disorder, and they are prescribed to people with bipolar disorder every day. And oftentimes physicians can't diagnose bipolar disorder until they've seen someone become manic on an antidepressant for the first time. And that needs to stop. You know, this is putting a lot of people at risk. So yeah, sputtering.
Do you see there being a problem with these labeling these diagnoses, bipolar 1, bipolar 2, schizophrenia, major depression? Seems to me there's a lot of overlap, and even within these specific diagnoses, symptoms look a lot different for different people. So within bipolar 1, for example, you know, I had all these crazy psychotic episodes, very few depressions. Some people have depressions that are worse. And how might we rework this system?
I love this question because the rhetoric in mental health was a huge barrier for me in my work. And you know, finding new ways to talk about these conditions and not use these diagnostic terms was really what I think allowed me to connect with and hold on to a lot of people who would come to me for help who didn't want to see themselves as having bipolar disorder or schizophrenia. Those words are really, really, there's a lot of stigma associated with those words, and it's not helpful. And they're also, I think, not particularly useful terms. So we need different ways of describing these things. And I, you know, sometimes when I would be trying to convince somebody to try an antipsychotic medication, for example, I would use the term dopamine regulating medication, something like that. You know, I would try to find other ways of describing the ways that I was trying to help back then when I didn't know what else to do. And I do think we need new definitions. So for example, and I know, Ian, you feel uncomfortable when I bring up your work, but the reason I'm bringing it up again is because it was just yesterday that I read your paper and your new paper on lithium and how it affects insulin signaling in the brain, which is an excellent paper that anybody interested in how bipolar disorder works should read. But I think you had said something in your paper about bipolar disorder being a disorder of energy regulation, and could we come up with a term that encompasses that sort of brings that concept to the fore? Because if I think that my brain energy is being dysregulated, then I can think of it as a biological metabolic issue rather than an incurable mental illness that I'm going to have for the rest of my life that's going to require medication and possibly lead to disability. I think it's a much more hopeful, empowering concept. I think one of the things I love about practicing this way is that I used to spend all of my time managing medication side effects, trying to convince people to take medication, trying to find ways to get them to accept trying one more medication because I didn't know what else to do. And I think most psychiatrists out there, if they're being honest with themselves, have run out of ideas for most of their patients, and it's a terrible feeling. But now, if I explain to them that, you know, that these are biologically based brain disorders, which are rooted largely in metabolic dysregulation, which nutrition can impact in a tremendous way, then maybe they can conceptualize the condition instead of, you know, being kind of a passive recipient of a diagnostic label. They can, you know, maybe it's not all about your childhood. Maybe it's not all about, you know, a serious trauma that you've not able to recover from. You know, maybe the condition that you're struggling with is based in biology and has a treatable and perhaps even reversible underlying cause that you yourself can enact. You yourself, because I can't do it for you. I mean, I can't do the diet for you. You have to do it yourself. But that puts power and control in the patient's hands. And it's completely different dynamic when you work this way. It's collaborative. It's about curiosity. It's about discovery. It's about, oh, let's see what happens. Let's see what's possible for you. I'll help you do it safely, and if it doesn't work, you can always go back to eating the way you were before. But let's see what's possible for you.
I want to be respectful of your time, Georgia. Do you have a few more minutes, or do you need to run to something?
Absolutely.
Great. I'm really interested in what you said about energy dysregulation, and I'm sure you noticed this with thousands of patients that you've seen, that their energy fluctuates up and down very wildly. And I always have liked these signaling explanations, because it feels more intuitively, in things like Alzheimer's, this very long-term degradation and there's structural damage to the brain. But in bipolar, like you say, people can have a normal day, a couple of days a month, where they feel normal. They feel like, oh, I could actually live. And I remember so many times, walking out the front door and thinking, my goodness, I could have a normal life. I could, I could become an author. I could start a family. And then 2 days later, I'm like flat on my back, struggling to clean my room. It's unbelievable how much your energy shifts. And so to me, these signaling explanations always felt more intuitive, because your energy can shift so rapidly. And I think it's really under recognized that that's the case. And there's obviously long-term damage and structural damage that happens with bipolar in the long run, but I think there's definitely something to be explained, and it will come from these conversations between people like yourself that are seeing this with patients and the scientists. And I really think we're all speaking the same language in a lot of ways. When you read papers on lithium, they talk about a lot of metabolic mechanisms, but they're never given that context. They're always given a different context as neurotransmission or synaptic function. But actually, when you start to read them through the lens of metabolism, a lot of them, I think, really start to make sense. So a lot of people that watch this podcast are people that are working on clinical trials at the moment through the Buzuki Foundation, people like Dom D'Agostino, Shabani Sethi, Jeff Volek. And you have a wealth of experience of working with people directly with ketogenic diet and training people in how to do this. What advice would you give to people that are working on trials at the moment from someone that's been doing this for a very long time? And what things would you highlight as being very important for the next stage of trying to show clinical evidence for a ketogenic diet?
Yeah, well, I am so excited about the clinical trials that are underway, and so grateful to all of the researchers who are doing this work, such badly needed work. The kinds of things that I think about, if someone were to say to me, oh, what would you want to make sure that we do in a clinical trial? The kinds of things I think about as a clinician are perhaps more nuts and bolts type considerations. But for example, what every patient and every clinician wants to know is, does the depth of ketosis matter? And this is one of those questions that I'm sure will be addressed in a lot of these trials, is that measuring ketone levels, is there a threshold effect? Is there a therapeutic window? Does everybody even need to be in ketosis? Because some of my patients don't need to be in ketosis. Others of my patients notice a very specific range where they feel their best. And it's a little bit different for each person, although sort of moderate ketosis seems to be, between maybe a threshold of like 1.0 or 1.5 or something like that. Good things start to happen above 1.0 for a lot of people. And bad things can happen to a lot of people if they go too high. And so if the ketones are really are hovering above 3 most of the time, that's for a lot of my patients very uncomfortable. And sort of, does the depth of ketosis matter? Does the consistency of ketosis matter? And does ketosis matter for everybody? So measuring ketone levels, blood ketone levels, serum beta hydroxybutyrate, critical. And I heard a rumor, I guess, that there will perhaps soon be continuous ketone monitoring possible, which would be incredible if such a device could be used in clinical trials to see whether there's any relationship between what people are experiencing and their metabolic state. And then CGM, would be really fascinating. I would love to see is a run-in period using a CGM on whatever diet the people are eating now before they start the ketogenic diet, and documenting along with the CGM data. For people who don't know, that's a continuous glucose monitor where you can see your glucose levels change virtually in real time, even overnight. Documenting mood states and seeing if there's any connection between glucose fluctuations and mood changes, and then switching to a ketogenic diet and seeing what develops. I mean, you'll see with the CGM, the glucose will come down to normal healthy range, of course, and be much more stable. But and to see how long it takes for mood to improve, and as both of you know, for some people it's as little as 3 days. In as little as 3 days, some people feel significantly better. Other people, it takes closer to 3 weeks, sometimes a little more. And I'd love to see, I think it's really important to measure medication levels before the ketogenic diet is started, and then to measure them again at 6 weeks or earlier if it's clinically indicated, because this diet does have profound metabolic effects. And that's the power of the diet, is it's actually a powerful metabolic intervention. The downside of that is if you're taking medication, your medication levels could change. And this is particularly true with anticonvulsants and with lithium. But I think it would be wonderful if in these studies, no matter what medication the person is taking, that all medication levels are measured and monitored, so that we really need that information to more safely guide people on the diet and advise people about the diet, about what to expect. And so I think that would be really important. And it would be wonderful to include in all of these studies at least some patients who are not taking any medication, because the ketogenic diet, and this is just my experience, it's much more difficult to embark on a ketogenic diet when you're taking medication than when you're not. And that's because medication affects brain chemistry. It's designed to do that. And the brain is the seat of metabolic and appetite regulation. And so it's just a different experience. And so I think it would be really nice to have some patients who are not taking medication to see, to sort of compare, in real time what's happening there. Obviously, electrolyte supplementation, everybody already knows about, but if you have good electrolyte supplementation, you can minimize a lot of keto adaptation effects. And if you start the diet gradually over several weeks rather than all at once, you will minimize the low risk. It's not a large number of people, but there are a small number of people who will experience psychiatric discomfort as they adapt to the diet. This is not most people, and you can minimize or eliminate this risk almost entirely if you gradually transition to the diet. And a lot of my work is supporting and educating people through the keto adaptation period, because so many people consult with me and say, I started a ketogenic diet, I tried it for my depression, or I tried it for my bipolar disorder, I tried it for ADHD, or whatever it is, it didn't work. And so, and it actually, they'll say it made me worse, made me more depressed, more anxious, etc. Well, how long did you try it for? Were you taking electrolyte supplementation? Did you ease into the diet? Were you measuring ketones? All of these different things, that can be helpful to people. So sort of getting a better handle on what's going on psychiatrically, what's going on at the level of brain chemistry when people are adapting to a ketogenic diet. So I think any insight into that process would be welcome, because I have lots of theories about what might be happening, but we don't know if any of these are true. So, and of course, measuring things and imaging things. So cerebral glucose metabolism, PET scans, glutamate levels, brain glutamate, that is fascinating to me, with MRS, lots of different, measure as many markers as you can afford, so that we can learn more about what's happening. So I guess I would stop there.
That's fantastic.
I want to remind people that I want to second what you said, first of all, because when I went on keto, I was on Zyprexa, and I do wish I had been able to do the diet with no medication, because I suspect the Zyprexa affected my insulin sensitivity, which in turn made it more difficult to enter ketosis. However, I went on the diet and stayed on my medications, and I'm on the gradual process of tapering them over a period of months. I also had to do a benzodiazepine taper, which was very difficult. I was getting off Valium, which I was effectively addicted to. And then I got off it over years, actually, on keto. And it was far easier than a lot of the anecdotal reports I've read on Benzo Buddies of people doing the same thing on a high carbohydrate diet. So I think the restorative effects of this diet were just scratching the surface of what it could potentially do, or the metabolic intervention, I should say, which we use the diet to access.
Yeah, I'm so glad you mentioned that, because anybody who's listening, and I know you emphasize this frequently on this podcast, but anybody who's listening who's considering trying a ketogenic diet for a mental health condition, I mean, there are definitely some people, if you're not taking medication and you have no history of serious symptoms such as psychosis or self-injury, suicidal thinking, aggression, etc. If you know, there are people who can do this ketogenic diet, who can try a ketogenic diet safely without a lot of medical supervision. However, if you're taking psychiatric medication or have any history of any high-risk symptoms, it's really important to work with somebody to help you navigate the keto adaptation period, because some people do feel worse before they feel better. The problem is finding a clinician who's willing to support you while you do this diet. So, so please, please learn more about it before you try it. And one of the other things I want to mention is that later this month, so we're creating a searchable international database where you can find a listing of clinicians around the world who will support you on a ketogenic diet for a mental health condition. These will be prescribers and non-prescribers alike, and it will be an international directory, so that if you're looking for somebody to help you, that should be up and running in the next several weeks. And I would also welcome any practitioners out there who offer these services in their practices to contact me via my website, and listing your service there will be free. So this is just a free public service to try to help with all of the messages that all of us who do this kind of work get every week, dozens of messages, people looking for help. So this is another way of trying to help with that problem.
That's so exciting. And we'll put the link in the video if we can catch up with you in a couple of weeks or whenever it's up online. But yeah, thank you very much for all you've done to bring attention to this, and for now making it available to so many clinicians and helping people find ways to use this, to find people that will help them to do this. It's just made such a tremendous impact. And but just thank you from a patient perspective that you really listened to your patients, and when you saw something was working for them, you didn't just say, okay, well, that's a bit risky, we'll leave that. You actually went full on and jumped off the main ship and got on this you really got on a life raft and made it work. And that's something that's extremely difficult to do and very rare. So thank you for doing that. And I'm just so glad it's led to you being a really successful psychiatrist. And I'm sure there's just going to be thousands and thousands more people wanting to work with you, because as knowledge about this increases and gets out. And but yeah, thank you. Every time we do these podcasts, we notice like a couple of things. And one is that it's people who really listen to patients that are doing this. It's people that the most who listen to their patients, and people who are also just really smart. And so thank you for being both of those things. And we hope to, it'd be lovely if you would come back on the podcast again sometime. We could do another discussion about your book and as that develops.
I'd be happy to come back. And I just want to thank both of you for everything you are doing to advocate for better treatments in this field, particularly metabolic interventions, and for sharing your stories. It's a courageous thing to do, and a really, it's a huge public service. And I hope that, and that's why I love sharing your podcast, because it's hard sometimes to reveal that you've struggled with a mental health issue, particularly if you're in certain professions. But it is becoming, perhaps because of the social media age and people being less concerned about privacy in general, people are feeling emboldened. People are feeling that they can speak out more than they could 10 years ago about mental health conditions. And I think that that's really going to make a huge difference in people seeking help and in seeking new types of treatments. So thanks both of you for all of your good work.
Thank you very much.